I am honored to have with me none other than the senior cardiologist, Professor Avijit Lahiri, sir. Sir is the senior cardiologist, British Cardiac Research Trust, London, and the Willington Hospital, London. So glad to have you with me, sir. So I would like to begin with, can we just throw some light on the incidence and the occurrence of heart disease in the diabetic patients, sir?
So, according to the WHO, there were in 2003 there were 200 million patients worldwide, and the number was supposed to increase to 400 million by the year 2025. But we are over 500 million patients worldwide already. So the estimate figures by the year 2035 is over 600 million diabetics worldwide. The problem is that it is a condition which affects the younger people between the age of 45 and 60, and 60 to 70% of the patients will die with a heart attack. But the majority of the patients, the disease is silent in the early period, and by the time the patient comes to a cardiologist, usually it's too late because the disease is advanced. So we have to find a way of checking the disease, at least in the high risk diabetics, early on, because diabetes is a bag of disease. Diabetes, high risk, hypertension, high risk hyperlipidemia, they all combine to make this metabolic syndrome, which then promotes early development of vascular disease.
Right, sir. So, sir, as most of the patients are really asymptomatic if they are diabetic, so it becomes very challenging for the early diagnosis of such patients. So, what is the role of cardiac CT in such kind of patients, sir?
So, it's a very important question that you ask. The fact that there are so many patients who have silent disease and they are relatively young, we have to find a model of how to do it. Cardiac CT is a very good test, but you can't apply it to everybody.
Right, sir.
There is a part of cardiac CT which is called coronary artery calcium imaging. Coronary artery calcium imaging can be done within 30 seconds, does not require an injection, and the radiation dose is very low, particularly with the new machines. But that coronary artery calcium imaging only provides the baseline knowledge, yes or no, whether atherosclerosis is there in the coronary arteries. That's an important question. If the amount of calcium is very high, then you suspect blockage. But the CT coronary angiogram is another method, but that is a method for use in patients who have symptoms or in patients who have very high risk that you've seen with coronary calcium. The score is above 400, then you can use a CT angiogram. Then you can look at the inside to see if there is a narrowing. However, even that is a big challenge. So I suspect that if we have a model where you take the risk factors of the patient and you have new novel biomarkers which look at the turnover of coronary atherosclerosis inside, and these biomarkers are just a blood test, and then you have the CT, then you can create a model. So risk factors, biomarkers, and then you have the CT. So you can then reach a bigger population cost effectively, and that was the presentation of today.
Correct, sir. So, sir, what are your views on the availability of the novel biomarkers as far as the diagnosis is concerned?
Well, some of the novel biomarkers are already available, like osteoprotegrin, high sensitivity CRP, interleukin 6, TNF alpha. These are possible to do. But biomarkers are not hard to manufacture. As you remember that 10 years ago, you couldn't get high sensitivity CRP. Today it is routine in every department. So the question is, first we have to find out which one, in doing trials, which one is the best. You take say a dozen of the best biomarkers, one to look at atherosclerosis, one to look at the turnover of plaque, one to look at cell death. So we can then say, okay, these are the 3 different groups, and these are the 4 or 5 best biomarkers, then we could apply that science, and then to make biomarkers would be cheap. Some big company can make it for nothing.
Right, sir. So, sir, what key message you would like to give to the cardiologist as far as the diagnosis of heart disease in the diabetic patient is concerned?
I think it's a national problem. The loss of life, loss of work, and it is estimated that diabetes and coronary disease will cost over 30 trillion US dollars in management.
Okay.
So we are talking about a massive, and if 30% of our Indian population is diabetic, can you imagine where we will be in 10-20 years time in managing the crisis, there will be epidemic crisis of diabetes and heart disease. So it is extremely important that we try to do research, because there are ethnic differences between Caucasians and Asians and Africans. So I think that if we could do a big trial in India, which is not going to be very expensive, but done in multiple centers, so you have the north, south, and different populations within the country, and then do this trial here, we could then find out what would be the best to serve an Indian population.
Right, sir. So, sir, thank you so much for such a wonderful discussion on the managing and the diagnosis of heart disease in diabetic patients.
Thank you very much,
so much, sir.
Thank you.